So you know you're gonna have the, so already we have gone through part of this PowerPoint with the hemophilias. The deep, large spreading hematomas, hemarthrosis in the joint area. So we've already discussed these three. On your sheet, afibrinogenemia is your first one. That's going to be a potential case study. And probably that'll be the only other case study besides DIC and primary fibrinolysis. So you probably only have, unless I get to the circulating anticoagulants, you'll probably only have maybe 3 case studies. The other factor deficiencies, you already know your test question. Pick which 2 you want to tell me those 4 things about. It'll be an essay worth 8 points. So you're going to pick any 2 from this sheet that you want to give me all that information about. So you already know one of your test questions. And your 1 case study is going to be afibrinogenemia. The most common one is really hypo, when it's just a low fibrinogen level. That is going to be your most common one you will encounter on a day-to-day basis. And if anybody does a factor assay, they're going to choose to do factor 1, which is what we've been doing in lab. Because if your ProTime and PTT are elevated and you know you're not on an anticoagulant, that's the first thing you want to check. Do they have enough fibrinogen? So the most common deficiency is, a most common factor assay is going to be fibrinogen. But this minimum for hemostasis, I wanted to point out. I think this is really interesting, how well you can work with not having enough clotting factors. So take a minute to look at your minimum. You do not have to have 100% to clot properly. So what they're telling you, you'll still clot even if you're down to 50 milligrams per deciliter. And we already said normal is 200 to 400. Many of the clotting factors, when you see the percent, if you get I would have loved to work in a specialty coag lab. I often thought at that time I should have went to SLU because they had the best one in the area. But factor assays, they measure each factor's activity in percent activity. So for example, if you look at factor 8, normally it's 50 to 200% is normal. They're saying you can get by with only 30% activity and still clot if you're that low in your factor 8. So the doctor, if he thinks you're severe, you might have 0 to 5% activity. You're thinking, my gosh, that's almost nothing. That's severe. Mild would just be the 20 to 30%, and you might not show any problems. What this is telling you, your clotting factors can work even in slow amounts. Remember on the platelet disorders, acute is self-limiting. It can get down to 20,000 and you still may not bleed. What's normal? 150,000. Your body can clot and work fine even with low amounts. So sometimes unless you have a procedure that puts a stress on your hemostasis, bless you, you may never know. Like the case we had of the 18-year-old, they all had von Willebrand's. We only found out because she had a pre-op testing. She didn't have any symptoms all her life. You might be just a mild in any one of these and may not show anything till they maybe have to do a test for you on a pre-op, or you have something traumatic happen like a car accident. What this shows you, look how low it can go before you have a problem. Some of them are unknown, like there's a rare thing with factor 12. So we'll try to pick out key things. I love factor 13. That is one of my favorite ones. And I'd probably pick maybe hemophilia C, or my other one I love, Hageman. Factor 12 is weird. You don't often bleed. A lot of times if you have anything, they're asymptomatic or they clot. So factor 12 is a weird one. So I would pick something that maybe look and see if there's some weird bleeding associated with one. I would find something of the factors that stands out to you that sets it apart. The big thing on every factor, you got to tell me what's elevated, pro-time or PTT or both. You got to know that on every factor because that's knowing your clotting factors in each system. Hey, let me know, you guys, that if you can you see it at all into our lab on that row? You can't. Okay, he's supposed to come here at 9, so you can compare it from Sysmex. And he said he came the other day. I was on a clinical visit, so he kind of knows where he's going. Okay. So we already know hemophilia A, we already know hemophilia B, we already know von Willebrand's. A, fibrinogenemia. If you look at that sheet, where I got the umbilical stump bleeding, look at the bleeding symptoms on the far right. I tried to pick something if I could find something that set it apart. Okay, you don't have to give me the whole list, but if you can look at whatever 2 factors you pick, if you can look at something that you can remember about that factor, then you just have to give me something, and I'd rather have something that sets it apart. So that's why I chose to put umbilical stump bleeding, okay? Because not every factor deficiency does that. The one thing that I would want on, if you pick A, fibrinogenemia, or I give you a case study, the one thing, what was the test we just did that was the factor assay of 1, was the fibrinogen. Would this fibrinogen be normal? If you have A, fibrinogenemia, it can get down to 50 to 100 milligrams per deciliter, or they say, I like it better per deciliter. I really don't know why they put percent, because that one we always do per deciliter. So if you want to change that on the first one, I would put per DL. That's what you're going to report out in the real lab. I don't know why the textbook put percent, because that one's not done in percent activity. So I would change that 50 to 100 milligrams per DL, because that's what you're going to report in the real lab.
What is TCT?
It's a thrombin clotting time. We used to do this test many years ago, and I did it in class, and it didn't feel good. You would put your blood pressure cuff for 5 minutes between 70 and 90. So we usually just set it at 80 millimeters of mercury pressure. And that is hard for 5 minutes. And look for petechia to develop in your elbow area. That was called the whole blood clotting time, and that's not done anymore. So I would put a line through that TCT. I don't think anybody's, remember some of my favorite books for Harmony, because I think they lay things out so much easier. The big thing is for afibrinogenemia, you're going to have an elevated pro-time, an elevated PTT, and a decreased fibrinogen on the test you just did in lab. So if anybody chooses that as their clotting factor, you make sure you tell me it's a low fibrinogen, because that is a classic test for that factor. So there's easy bruising, ecchymosis, gum bleeding, hematuria, poor wound healing, but the biggest, poor wound healing might be another one that sets it apart. I don't care what you pick as long as it's one valid one. You don't have to give me the whole list. Just give me something that goes, and that's why I give you the chart. I think this chart's easier to study than paragraphs in a book. Hypofibrinogenemia is what I think you're going to all see in lab. And it's a weird one too. You might have mild bleeding, but there can be a thrombotic tendency. I don't know why 12 and low fibrinogen. Remember what I said about fibrinogen? You'll learn in serology, it's an acute phase reactant. When you have inflammation or something, you can have elevated fibrinogen because it is something that helps draw your phagocytic cells to the site of injury. They call it an acute phase reactant. Yes?
Sorry. It says hypo is low and A means there's no fibrinogen, but you still want us to say it's just low fibrinogen?
It says it's no clot formation, but you can just say it's extremely low.
Okay.
For hypofibrinogenemia, let's say 50 to 100 and 50 to 190, let's say, if you want to write under by hypo, and let's say A less than 50, if that helps you clarify it. So let's clarify it for less than 50 for A fibrinogenemia, and hypo, let's put 50 to, let's say, 190. I know all of you are going to see some low fibrinogens. If you have the luxury of doing fibrinogen at your lab, we'll keep hypo between 50 and 190. If it's less than 50, we'll go with it's an A fibrinogenemia. That'll help clarify for you. A is worse, but it's extremely rare. You're not going to have too many people walking around with no fibrinogen and living. Now there's a weird one that's dysfibrinogenemia. I don't know if any of you will ever see it. I've never seen it in my career, where the number is normal, but it's not a normal form. The fibrinogen molecule is abnormal, although there's enough of it. So you could do, like it says, the key thing you want to flag on here, quantitative is normal, but the molecule doesn't work properly because it's abnormally, kind of like your Landsman's and your VWF. You will have an elevated bleeding time, right? Because it's a qualitative problem why the platelets can't function. So the problem here is you have enough fibrinogen, it's just not, it's like a mutated fibrinogen molecule that's abnormal. So it doesn't do its job well. Okay, so the A fibrinogen, so the big thing you want to take away, umbilical stump bleeding for A fibrinogenemia, you're not going to have many times in hypo. If you're between 50 and 190, what is your minimum hemostasis? 50 to 100. Are you going to probably bleed? No. So you're probably on hypofibrinogenemia, not going to have any bleeding symptoms often. So if you want to choose this, I would choose A fibrinogenemia, less than 50 milligrams per deciliter. And what tests are abnormal? The ProTime won't work, the PTT won't work. You need fibrinogen to form the fibrin clot. And your fibrinogen level is very low. Okay? Umbilical stump bleeding. And how is it inherited? Autosomal or sex-linked? And I don't care if you say recessive or dominant, you just need to know autosomal or sex-linked. How is it inherited? Okay, so do you see it says underneath it's autosomal, okay? So I would flag autosomal, flag there's abnormal ProTime PTT and your fibrinogen test. You know how some of you kept plotting and going forever, the seconds ticking away? That's what it would do. When they say no clot detection, you'd go to your highest seconds on each machine. What was it over on the start fours, like greater than 200? When something didn't work, didn't keep going to like 200? Each machine you work on in a lab is going to have its limit that it'll keep going. And then we used to have one machine would say NCD, no clot detected. So I don't know what all the analyzers would do in each coag lab you go to, but they'll have some endpoint that the machine finally says it doesn't clot. So if you pick that one, your abnormal screening tests have to be increased ProTime PTT and decreased fibrinogen. So if you're going to pick, probably the best one to pick out of those three are the A fibrinogenemia. I know everybody will see hypofibrinogenemia. And I think I want to go, I know I have 20 to 100, but based on this, I change that in your PowerPoint to 50 to 190. I want to keep it consistent because with this sheet, how it goes, we're going to keep it at a higher level. That way you can distinguish afibrinogenemia. So we'll keep it less than 50 for afibrinogenemia and 50 to 190 on hypo. That way we'll be consistent. So every factor, you should be able to tell me at least what is elevated pro time and PTT. So factor 2, what's going to be elevated? You should be able to think, not even have to think about it, by knowing your clotting factors in each system. If you have a factor 2 deficiency, what's elevated on your test? Both. If you have a factor 5 deficiency, what's elevated on the pro time PTT? Both, because it's a common factor. What about factor 7? Pro time only. What about factor 8 and 9? PTT only. What about factor 10? Both. What about factor 11? Okay, factor 11 is intrinsic only, so PTT, right? So it's 8, 9, 11, and 12. So if you have factor 12 deficiency, factor the PTT. Every one of these, I should be able to say what happens in the pro time and PTT just by giving you a list, and you should be able to tell me, okay, by knowing your clotting factors in the pro time and PTT. So factor 2, it doesn't have a lot to set it apart, so I chose post-op bleeding. If you look at your sheet, it says post-op bleeding, epistaxis, menorrhagia, easy bruising. A lot of common superficial bleeding. So I would pick a clotting factor for the essay question that you can retain something that you need. So you would say post-op bleeding, you already told me it has elevated pro time PTT. How is it inherited? Autosomal. And we know it's the post-op bleeding. Oh, there's some screening test, pro time PTT. And how do you treat? The first choice is what? Prothrombin complex concentrate, because what's in that? 2, 7, 9, and 10. Or you could pick FFP. Somewhere on this sheet, right, FFP has all the clotting factors. I'll be right back, you guys. Hey, Diane. This is Barrett.
Well, and I already have one of these yesterday. I got the reading on, but it said it would not print the output. And it's been happening slowly. Yeah. Okay, Diane is our new college instructor. Also has a lot of experience in
What do you need me to do?
We already know it's going to have, I'm not going to have you know, 5 has a little bit of a role with the platelets, but only on your test you have to know it's an abnormal pro time and PTT. I'm not going to have you know anything more than the BS, the GT, the VWF affecting your bleeding time. So anybody who chooses 5, but look what was hard about 5, was there anything to set it apart bleeding? No. So if you choose that, it's just your normal superficial bleeding, like your nosebleed, your heavy period, easy bruising. And so far, have you noticed the common theme of genetic? Everyone's been autosomal. So you shouldn't have any issue remembering the genetic on one of those 2. Yes?
I was going to ask about the dysfibrinogenemia.
The dysfibrinogenemia?
That one. It doesn't say autosomal, so it is autosomal.
We're going to, all of them, we're going to say, yeah, we're going to keep the dys as an autosomal too, because the only sex linked are the 8 and the 9, okay? So you already know, and if you can tell me what the pro time and PTT does, The only other one you have an issue with is if you pick the fibrinogen, because that naturally is going to have a low fibrinogen. So you should already know your screening test, no matter which one you choose. If you don't choose factor 1, it's going to be whatever system it's in, the ProTime or the PTT. So remember, you already should know some of this based on what you know about a ProTime and PTT and the intrinsic and extrinsic. That's why the hard part for you is going to be picking one that you can remember the bleeding symptom. Okay? You all know they're autosomal already. Pick a symptom of bleeding that you can relate to. So we already did 5. 7, it's autosomal. What does it have that's unique? And that's what I put. 7, I put cerebral hemorrhage, because that was something that set it apart. You know, so try when you're studying to pick something that set it apart. The biggest thing you're going to know need to know for your day-to-day lab, and who was I just talking to yesterday? It is incredible, they said, how little you use from all you who teach us. But if you don't study it, you will not pass the registry. Until they change the board of certification exam, I can guarantee you, if you only work on normal patients at the lab and never study any of the theory we teach you, you will not pass that. Until they change that BOC, we have to teach what they say. And students often come back, well, shoot, we hardly used any of that. Well, then tell the BOC people, I can guarantee you, you won't pass. Jason one time came back from a clinical, this was many years ago, and he had to come back and start over with a new class because he had left for a little while and came back. And he had had a clinical before, and he was trying to tell him, oh, you won't have to know all that. I'm sorry, you will not pass it. So we don't make this up. I would love to teach less, so would everybody else, but we got to get you to pass that test. I don't care if you finish this program, you don't pass that test. Most places in a year, you're done. And Barn, BJC, and a lot of people love to go to BJC hospitals, you're done. And I've had one let go at Alton. He never took it, and they kept telling him. And he was a really good student, never took it, and he was let go. So, and I have one that might be getting let go at Barnes. It's the only person that hasn't passed for me in probably 4 years and hasn't passed, even the repeats. And I'm sure she took 2 of them very close together. I'm sure it's because she was near her year. So that is the deal. You gotta pass that test, despite what you do here.
You take it 20 times as you want.
I think I've had someone pass it on the 4th, and that student had to come and do like my review class and things to prove, and it worked. The review class, it did it. But a lot of people will minimize the theory. You can't. The BOC is all about the theory. It's not just how good you can run that machine in lab. They want you to be knowledgeable besides being able to push a button or a pipette or whatever. Yes?
Is this field that we're studying right now, could it get us a position with the CDC?
Is it what?
Could this position give us a job with the CDC?
CDC with microbiology, I don't know what their expectations are if they want an MLS or an MT, but CDC is big time with all micro, especially anything infectious. I already have a couple more one girl's gonna come to the review class that is at her 2-year with her bachelor's. I have a person come from Carbondale that teaches you how to do a bachelor's on every other weekend. And they even give you credits for work experience. They give you credits for 9 of the MLT courses, and it's at Scott Air Force Base. And so I have that person come because it's the fastest way I know for people who have the MLT AAS only to try to get a bachelor's, because all of you are so smart if you can do the math and the science and the chemistry, the anatomy and the chemistry. So everybody's goal should be the MLS. I don't care where you're at right this minute, I give you tools to get that far. Because we need, and in that way there's no restrictions on where you work, because you at least get the bachelor's MLS. CDC, working in micro are tough without MLSs. Breeze and Memorial have 2 of my MLTs in their micro. Christian had one of my MLTs in the micro. It's not always easy to get your foot in the door in the micro department without being MLS. It's just tough. It takes almost a good year for someone to get good in micro, and you'll see when we get to it. It is a butt kicker course. It is so much information, and I find it so exciting and challenging because it's hands-on. Some of you will love the automation. I was never one into just putting it on the machine, letting it go, turn it out. I like being involved. I love doing diffs. I love anything that you get to be a part of. So your goal should always all be the MLS. I don't care how old you are, that should be your goal. Your job can help pay tuition reimbursement. I got my master's, my first master's with tuition reimbursement all but $1,000, and I'm on my second master's now, and I'll have paid for books because of tuition reimbursement. Use your job to help pay, and see, don't stop, because a lot of you already, look how well you work together, look already how you become a team in 2 classes. It matters. You guys are already displaying tools of leadership. It's just all about you. You'll help someone who needs it. So as long as I'm the program coordinator, everybody, I'm going to encourage them to go further than the MLT, because I want you to be able to get any job in our field. Not just, oh shoot, they only do MLSs, so you only can do some states. They don't even let MLTs do more than blood trying and maybe wave testing. In our state, we get to do almost everything as an MLS between St. Louis and Illinois. So we're lucky. You guys are in a great area for getting to develop your skills and not being an MLS. So that should be your goal, every one of you. Okay, so factor 7, cerebral hemorrhage. I don't care if you put FFP, just know that FFP is fresh, frozen plasma. It has all the factors. What did you say the PCC had? You gotta know what's in it. Prothrombin is the prothrombin factors from whatever lecture that was. 7. You can pick either one of these if you choose factor 7, and it'll be correct. So far you know they're autosomal. You at least should be able to tell me what's elevated per type or PTT. You just got to learn the bleeding and the treatment. Factor 10, you already told me it's elevated protein PTT. We know it's autosomal. Factor 10, I think I picked CNS bleeding. That stuck out to me as something that set it apart, but you can pick any bleeding you want from this sheet. I just tried to pick things that made it stand out to me. Okay? And it says treat with PCC, because 10 is in that, or you can pick FFP, so I don't care. So you already know, autosomal, increased protein PTT, CNS bleeding, treat with PCC.
Does FFP have to be typed?
That one, I think, has to be type specific. Platelets don't. You can give platelets from any type. But FFP, and Barb's here today, I'll make sure, I'm not telling you wrong, but FFP, I'm pretty sure you have to get the type you are. So you're going to learn about blood products. For us, for coag, blood products you're going to get are platelets, fresh frozen plasma, and there's a neat one called cryoprecipitate, which has 1, 8, and 13. That if they know you're really low on your fibrinogen, they may give you cryo and then instead of all the factors, because it has a lot of, or maybe if you're mild hemophiliac, they might say, let's give you cryo and not factor 8 concentrate from so many sources. Because remember, they screen our blood now for HIV, but it's still not foolproof. What if you give blood? And some places give blood, you can get money for giving blood. So what if you're one of those areas that you just are HIV positive, but you haven't built the antibody, and when they screen you, you still screen negative. So our system isn't foolproof. You gotta give, antibodies take some time to develop and be detected. So our system is way better than it ever used to be, but it's not foolproof. Factor 11 is your hemophilia C. It's autosomal, so this is different from hemophilia A or B. So that's something interesting. This one isn't sex-linked like hemophilia A or B. It's the least of the 3 that'll show up. And factor 11, I chose Factor 11 is down there at the bottom. I chose the retinal hemorrhage because I thought it was something that set it apart. So this one would be an interesting, if you remember, it's not sex-linked like hemophilia A and B. It has the retinal hemorrhage and has the elevated PTT. And once again, you could treat with FFP if necessary. I like 12 because it's a weird one. 12 does not usually have bleeding. If they do anything, it triggers thrombosing. And I don't really know the explanation, but sometimes they're either asymptomatic. The only thing you'll know is that the PTT is elevated, and if the doctor orders a factor assay, because what were the two common factors in AS and AP reagent? Do you remember? So if you get down to your PTT is elevated because of one of these, you still have to do something else. One of them is it's called a factor assay. They can say, I want a factor assay for 11 only, and I want a factor assay of 12 only. And we used to do them when I first worked at St. E's. And what it does, you use a reagent that gets every other factor up to 100%, except the one you think it could be. And you add that reagent to the patient's plasma. And if it's below the percentage for that factor, then you know it's 11. And then you do the same thing for a factor 12 assay. You bring up every level to 100%, but the factor 12. And if it's still elevated, you know they're missing 12. Well, the big clue, which of the two would bleed? If you're down to it's 11 or 12, which one has the chance of bleeding of the 11 and 12? 11. So if it's asymptomatic or they thrombosed and had a blood clot, you already know it's 12, not 11. Okay? So that one I like to pick because I just think it's a weird one. They're asymptomatic. You would know it's autosomal. They normally don't have any bleeding or they thrombose. It's an elevated PTT, and you're not going to treat. You're not going to treat them with a blood product, right? If they're asymptomatic or they're thrombosing, you're going to have to maybe anticoagulate, like Coumadin or heparin. So that one's a weird one. So I would pick any two that interest you and that you can remember. You tell me about 13. You already know. What about the proton and PTT? They're normal. Remember, 13 does not form the clot, so the proton and PTT are normal. So that's a good one to do because you say they're normal, and I'll teach you a test in test methods called the 5 molar urea test. They take this reagent called urea, it can be called the urea solubility, but it has urea in the reagent. You do a mill of it. You know how the fibrometer, you can see the hunk of like the gel, like snot looking thing on the end if you picked up the probe sometime and it was hanging? You take that clot, you stick it in the mill of this 5 molar urea reagent, and you let it sit for 24 hours. If it's gone the next day, they're lacking factor 13. If the clot still is there suspended, it's normal. And factor 13 isn't the problem. So this is a big test to know. It's abnormal 5 molar urea. And the clot, we'll learn about that in our lecture with test methods. So factor 13 I think is a neat one because you don't see usually till 36 hours delayed wound healing, and it starts bleeding from like a suture site. And you can treat with FFP, and if you want to put in parentheses, cryoprecipitate has 1, 8, and 13. So that could be a choice, or you can just say FFP. So I mean, if you're in doubt, you can go with FFP, and most of the time you're going to be right. 1, 13, 1, 8, and 13. And I'm not going to make you know for the test, but if you look at your little chart on pre-kallikrein, you can put NA. I'm not going to make you know them for the test. But both of them you should be aware that they have abnormal PTTs. Because what's their job in low concentrations? Remember, they're part of the kinin system. In low concentrations, they help factor 12 be fully activated. So you should at least be able to tell me if they're missing Fletcher factor or Fitzgerald factor, the PTT would be elevated. Okay, that's all I expect you to know. I'm not going to have you don't pick them as your case studies. Your case studies come from 2 of these, but don't pick 8, 9, or von Willebrands because we've already tested you on those. But you should be able to tell me that if you're missing Fletcher or Fitzgerald, you're going to have an elevated PTT because in low concentration, that is their job. And I think the 2 I want you to circle on this are the only 2 I'll have you know is the liver disease and vitamin K deficiency. There are certain conditions that cause acquired hemophilia or von Willebrand's. I'm not going to test you on those. But liver disease is one of the key problems for coag. You have hepatitis, if you have cirrhosis, if you have liver cancer, all of the factors but 3 get made by the liver. So if you have a condition that's not going to get better, you're probably going to have a coag problem that ends up affecting how you die. Because you can only give so much FFP to replace what you're missing. If you can never remake those factors, you're probably going to die with liver disease affecting it, especially if it's cancer of the liver and they can't cure you. So remember, liver makes everything but 3. So you're going to have these elevated ProTime and PTT. The doctor can give you FFP and it'll go down, but it's only temporary. So if they cannot improve you, you're going to have issues with bleeding, and you might bleed through every orifice, you might bleed GI. Remember, liver is a big deal if it's something acute, okay? The other one is your vitamin K deficiency. Someone who, maybe you've been in a nursing home patient that has been in the hospitalized, can't hardly eat, on IVs all the time, you may end up being vitamin K deficient. If they can't give you enough nutrients through IVs that you can't have enough vitamin K, remember 2, 7, 9, and 10, and even 2 of your natural inhibitors need vitamin K. I would say of this list, those 2 are going to be 2 of your big things I think you'll run into. So if you over-medicate someone with Coumadin, what do you think a treatment is? Vitamin K. They can give you a vitamin K injection and really help you out pretty immediately.
Where do you get vitamin K from naturally?
Naturally, your dark green leafy vegetables are a great source. Great source. So when they put someone on Coumadin, they're going to tell them dietary what to avoid because you might be ruining. Some people, you wonder if that's why they take forever to get properly in the INR. Remember what the INR should be? If you're on Coumadin, what the doctor wants, between 2 to 3, unless you have, a history of heart problems. So they're going to give you a diet to follow because otherwise it's pointless giving you Coumadin and you keep eating the stuff that has vitamin K. Some people get in their correct dose quickly, like a week. Some people, it seems like they're coming back weekly. I mean, monthly is probably a common one, those of you who work, that I would say they come in once they get established. But it's a big deal if you don't watch your diet. But I think these 2 will be the 2. Renal affects platelets more than clotting factors, but what is the problem with renal that you have to be aware of? What is the big thing that builds up? Those waste products. Your urea, the blood urea, nitrogen, your creatinine, the creatinine level, uric acid. Those things aren't good if they're in your circulation and you're not voiding them and getting rid of them in your urine. Okay? So, this is test 4, and we have to get through fibrinolytic disorders, which is a short PowerPoint, but it's not easy. But, what test did we just do that we're going to do the competency on first thing tomorrow? That was our last test you learned.
D-dimer?
D-dimer. Tell me what that tells you. Tell me what you remember about the D-dimer. It proves there's clotting because what breaks down into what?
Fibrinogen breaks down into.
The fibrin clot got broken down into what?
D, Y.
What were your early products?
X, Y.
Okay, and your late products were?
D.
And then how did you know it was the fibrin clot broken down and not fibrinogen broken down?
Fibrin clot makes the D-dimers, fibrinogen does not.
Okay, so the D-dimers, so we have X, Y, and D. Here, I guess I need to do from my plasmin and fibrinogen and fibrin clot first. Tell me, what are the activators? Because remember, if you understand your system, it helps you understand the disease states. What is from your kidney that is an activator? What is from two bacteria that's an activator? What's from the damaged vessel that's an activator?
Collagen?
No, collagen is what gets 12 going.
Factor 3.
Factor 3 gets the extrinsic system going.
CPA.
TPA is from your vessels, tissue plasminogen activator. The kidney one is urokinase. And the bacteria are streptokinase and staphylokinase that you can make from bacteria. We'll learn about them in micro too, that they're products that those strep A and Staph aureus produce. They can be used to activate plasminogen to plasmin. Isn't it great how we carry over not even from one test to the next? And you're thinking, how am I going to pass a BOC? Okay, so the D-dimer, the patient you look for D-dimer in the plasma. And the reagent had KIT, because this is going to be on your next test. That test method is going to be on the test. Has a KIT D-dimer antibody plus something to make it visible, the latex. So that's the principle. You have the D-dimers if they're not cleared by what? What clears them? The liver clears them. If they don't get cleared, they build up in circulation and they're dangerous. These degradation products, whether they come, they're FDPs, whether they come from the fibrin clot or fibrinogen, if they're in your circulation and you need to clot, they take you to surgery, you're going to have a good chance of hemorrhaging. Because X is the only one can clot a little with thrombin, the others inhibit clotting. So if the fibrinogen is saying, wait a minute, we're operating on this person and I need to form a clot or she's going to hemorrhage, and they're floating around, they're going to compete with what fibrinogen you have left. So this D-dimer proves that there was clot formation. They use it in ER a lot for people who have deep vein thrombosis, MIs, pulmonary embolism. If it's elevated, they know they have a heavy-duty clot someplace that they're trying to break down and there's too many degradation products to clear. That's the big use you're all going to see. You're going to get this test ordered often in ER patients that have blood clotting somewhere. But when it relates to coag, the big thing you're going to see is in DIC, disseminated intravascular coagulation. There's two disease states you got to know from this PowerPoint for your test, and your study guide, that sheet of what tests were elevated, are what you're going to have to know. What tests are elevated, because you're going to have to let me know what tests set it apart. Okay? So you got to know, you got to understand your test methods.
What does it say on the side? D-dimer.
the D-dimer it's the kit D-dimer antibody and the latex. That's what that little vial had in it. Yes?
Do they know why it is only formed with fibrinolysis clot versus a fibrinogen? Is it just not something you're going to teach in this class?
I don't know. I don't know the researchers of all this, who decides what, but whoever did the studies on the degradation products, I don't know, what test methodologies they use to determine.
It just seems inaccurate that they're going to break down into the same products but not do the same thing.
Right, but for some reason, when it's this being broken down, whatever this molecule looks like, when it's a fibrin clot versus the fibrinogen 1 factor, whatever is in this structure must have something that makes them join. Okay, the big deal with primary fibrinolysis, there's no clot formation. Remember the example I gave you why you could have degradation products from fibrinogen and not a fibrin clot? Remember what kind of procedure I said might happen? This is very rare that primary fibrinolysis happens. Think of one of the activators. Where could it come from? Urokinase comes from what tissues? Your urinary system. So if you have a kidney problem and they do an invasive urinary procedure on you to maybe check your kidney function actually, or even breaking up those, I could see where you'd release it, breaking up those kidney stones. If they're doing something that's like beating you on your back that you're really sore for days after, I could see that procedure in itself triggering urokinase. So the big thing, if you have primary fibrinolysis versus secondary, and DIC is secondary, it comes after another condition. I'm going to give you examples of what can trigger it. There is a list in your chapter on what can trigger DIC. And this has clot formation. This has no clot formation. So if it has no clot formation, factor 1 or fibrinogen is broken down by plasmin. If there's no clot, remember plasmin's actions, it's not all about just on fibrin clot. It can break down a lot of factors, and one is the big one. It can affect factor 5 and 8 as well, but one is your big one. And this one, the fibrin clot, is broken down by plasmin. So, let me give you some examples. The one I like to use on the test is always related to pregnancy usually. If factor 3 is released, and that's why the pregnancy one is really good. A case of the retained dead fetus, if you have a set of twins and one didn't make it, it's going to release thromboplastin as it dies. But the case I had, we had to check the mom because the other one was viable, and we didn't want to have her deliver soon if she went into DIC from factor 3 being released and triggering widespread clotting. Remember, DIC is disseminated. It's all over your circulation. Intravascular, within the blood vessel, coagulation, clotting. That's what DIC stands for. So that's the one case I've seen most commonly at my job when I was in heme coag UA serology is DIC. And we had a problem pregnancy patient. The other case we saw was if the placenta starts pulling away from the uterine wall, what's it giving off? Factor 3. So they start hemorrhaging. And the biggest way to treat DIC is to eliminate the cause. If you can take and deliver the baby, clear out all what's in the uterus, usually you can eliminate the hemorrhaging. If you can't stop the bleeding, they're gonna give them packed red cells. They might be giving them FFP if the hemorrhaging is so bad. Okay, that's the most common case I've seen, so I usually like to use a pregnancy problem in my case studies. Sepsis, especially a gram-negative sepsis. I'll just give you some other examples. Gram-negative sepsis, like a gram-negative would be like an E. coli, a Shigella. They can sometimes trigger factor 12 on the intrinsic pathway. And then do you remember what I ever told you about snake venoms? I thought I mentioned that one time. Snake venoms can act directly on factors in your clotting system. So let's say you have factor 3 being released from a pulled away placenta. Some tissue is giving it off, or the retained dead fetus. That's factor 3 getting the extrinsic system. If you have a gram-negative sepsis triggering factor 12, that's a way to start the clotting system. And if you have snake venoms, certain snakes start the clotting at factor 10. Certain snakes start the clotting at factor 2. Certain snakes go right to fibrinogen and start the clotting. So if you take the time to look at your chapter on, I think it's chapter 34 that has clotting disorders and fibrinolysis, there's a you take someone to surgery and you can trigger widespread clotting. We had a really sad case. I don't know if you know Dr. Ash, he's one of the regular surgeons in town, and I was working in COAG that day, and he had a patient going for a normal routine surgical procedure. I think the patient was a lady in her 40s, and he was so upset he came down after the surgery. She started blowing clots in all her extremities, and they ended up having to remove parts of her toes and fingers because they just blew clots all in her extremities. DIC, remember, disseminated intravascular coagulation. We're talking about acute, where you're primarily going to hemorrhage. If you have chronic DIC, you might clot everywhere and throw blood clots. So she was the kind who went into a DIC that triggered the clotting so much, they could never keep up with the clotting, and she ended up having thrombus, and they ended up being in her extremities. So DIC, if you take the time to read, DIC can be triggered by almost anything. A normal surgery, that's all she had was a normal surgery. But what do? You're cutting them. So you're going to release some thromboplastin, and it triggered widespread clotting, and everything went beautifully, he said. So the next day, they had to take her back to surgery because of all these blood clots that went into the extremities. So the most common one we see is acute, where these degradation products can't get cleared, and there's so many of them, they end up causing the person to hemorrhage. Because this, I said, is the only one, X is the only one could clot with thrombin. If you have an extra Y, D, and E floating around, you're not going to clot. And so they end up putting an inhibitory when you do need to clot. DIC is a tough concept. So let's go back to primary. So we know one has clot formation, one does not. And here are your degradation products in different forms. Yes?
I took my residents to the zoo, and there was one of the plaques mentioned that snake venom, or a particular snake venom, could help with diabetes. Why would that be? If it's going.
I don't know what else is in snake venom.
Okay.
That would help diabetes.
So they're extracting something they're not using, just.
There has to be something else in the snake venom they're using, because your diabetes, you can be a multiple types, which Barb will go into. Secondary, where yours just doesn't work well enough, but you have production. Some you don't produce it at all, so you got to give them in an injection. So I don't know what else is all in snake venom that they could use as a treatment for that. And I don't know, maybe she'll know in relation to diabetes. Okay, so this one we're going to say they had a urological procedure. They released urokinase. And it says, hey, I don't see any fibrin clots. So I'm going to break down factor 1. And I'm going to have X, Y, D, and E form, but no D dimers. And I can have problems with clotting because remember, X is the only one that can clot at all with thrombin. Y, D, and E will say, fibrinogen, I don't care if you need to clot at all. We're not going to let you get to thrombin to form that clot. So you end up bleeding. So let's put the test results. And this is something from your study guide you got to know for your test. So we have primary and secondary. We have a protein, we have a PTT, we have a fibrinogen, we have platelet, and we have B dimer.
And it's like FDP on
I'm sorry, what?
and FD.
I put a line through FDP because all the labs aren't doing FDP anymore, so I forgot to update it on this one. So we're not going to know FDP because it doesn't distinguish them, and all the labs have gotten away from doing FDP, so I said, okay, I'll drop it. Because it doesn't, it is an antibody to late degradation products D and E. And both these problems have D and E. So you would be positive for both, so it didn't tell you anything other than, yes, they have degradation products that aren't cleared. So I told him I would drop it since I can't find anybody that's doing the FDP anymore. So, why would you tell me, why would, if urokinase triggers plasmin to break down factor 1, why would protein and PTT be elevated in primary? What do you need to form the fibrin clot? Factor 1, right? And it's being broken down because urokinase said, hey, okay, I'm breaking plasminogen, I'm activating it to plasmin. I don't see any fibrin clots. I'm going to go attack their factor 1 and their plasma. So this is elevated. You're affecting factor 1. You got to have it to form the 10 to 13 seconds in the protein and the 28 to 36 seconds in the PTT. What about, do you think my fibrinogen level is going to be 200 to 400? It's breaking down factor 1. It should be low. Is it doing anything to platelets? Is that plasmin doing anything to platelets? Nope. So what should your platelet count be? And are there any D dimers formed when fibrinogen is broken down into X, Y, D, and E? No, they don't form unless it's the fibrin clot. Okay, so let's take a look at, and ideally, either of these conditions, if you can handle any bleeding that occurred because of that urological exam, you're going to take care of the problem. So you caused the problem by triggering the release of urokinase. And that went out to do its job, and all it could find was plasminogen to break in to plasmin to act on fibrinogen because there was no fibrin clot. This is the big deal. You got to know that there's no fibrin clot in primary DIC. That's why it's primary. Normally, the fibrin clot is what triggers the plasminogen. There's that thrombin in high levels, breaks plasminogen into plasmin. And that's telling you there's a fibrin clot. This is a big deal. Anything I box is a big deal. Okay? So secondary, and we'll review this tomorrow. So it won't be the only time you hear it. This is a tough subject. Secondary, we already talked by extrinsic, like the placenta pulling away from the uterine wall. We already talked about direct activation, example of snake bite. We already talked about sepsis can sometimes trigger and act on 12. You're gonna have clot formation. So what degradation products are you gonna have? Probably from both, right? It can break down the fibrin clot. It can break down any fibrinogen that you have remaining. So you're going to have a ton of X, Y, D, and E floating around. And are those D's going to join? Yes, because you're going to have the clot formation that triggered everything. So you're going to use up all these clotting factors in making the clots. Remember, this is widespread. It's disseminated. You're going to use up all those clotting factors. So your proton and PTT use up all clotting factors. Why is the proton PTT elevated here? What is it using up? What factor? 1, because that's all it could find to break down, right? The fibrinogen. And then the fibrinogen is being used up, so it's going to be low because all clotting factors are used up. And when you make a clot, do you do anything with platelets?
Yes.
You have your platelet plug that the fibrin clot joins to get that stabilized secondary hemostasis. So what is going to happen to your platelets? They're going to be used up in the clot. That's what has to be available, the platelet plug, for the clot to join it. And then do you have D-dimers? Are you breaking down fibrin clots? Then you're going to have D-dimers. So, for your test, you've got to know which one has clotting taking place and which one doesn't. So primary has no clot formation, secondary has clot formation. You got to know what tests set it apart. The platelet count is normal in primary, it's decreased in secondary. The D-dimer is negative in primary because remember the Ds don't join when fibrinogen is broken down. That's why it's negative. And the D-dimers are positive because the clot's broken down. So that is a key piece on your study guide. And test question, I'm going to ask you, what sets it apart? And you got to know which one has clot formation and which one doesn't. So this will be the 2 PowerPoints on your test. So your last test, unless we have time to lecture more before the next one, so far this will be what's on your test. Okay, so it'll be a shorter test than the last one. But the last test will be a big one. But some of it's treatment, and I don't think treatment's that bad. The treatments, the test methods, the substitution studies is the hardest piece, and I think you guys kind of get part of that already. So remember, on your test, if you want to pick 3 other questions as your bonus, you just let me know tomorrow. You can look it over. And then we're going to start with the D-dimer test, so we'll do that competency right away. Okay, I'll be back, you guys. You're ready to go. Thank you.